All right, so next we have Maple, nominated by 111. Maple, where are you? Ah, here it comes. And what you noticed with Jonathan on that last is if the pitch ends early, that just leaves more time for questions to the judges. So, ready? Ready. All right.
Great. I need
either one. Yep. There you go.
Wonderful. Well, thank you very much for having me. Sorry, it was a bit of a long walk from the back of the room. So without further ado, so what Maple is, we are Canada's largest virtual care network for 24/7 physician care. My name is Dr. Brett Belchetz. I am one of the co-founders of the business, also the chief executive officer by background. I'm an emergency room physician. I've practiced emergency medicine in the Toronto area for almost 15 years, although a lot less so since starting this company. I'm also a former consultant with McKinsey & Company, having left medicine for a few years to work as a management consultant. Those two interests in healthcare and consulting and strategy really came together to start this venture. So what is the problem that we're solving? Why did we start this business? So I don't think it's a secret to anybody who lives in Canada that it is very hard to access medical care for most of the Canadian population. And actually, I hear a lot from our friends here in Quebec that it's even a lot harder than where we are located in Ontario. So where I practice on an ongoing basis working in the emergency room over the last number of years, what we saw is that the average Canadian really has nowhere to go for medical care. So almost 1 in 5 Canadians don't have a family doctor. Of those Canadians that do have a family doctor, 50% of them are waiting more than 48 hours to actually get seen when they have a medical need. 1/3 of them are waiting more than 7 days to get seen when they have a medical need, which leads to about 47% of people who show up in Canadian emergency rooms actually going there knowing that they don't have an emergency. They're going there because they've got nowhere else to go. And we have the longest wait times in Canada for things like primary care, for specialist care, for emergency room wait times, for walk-in clinic wait times. So there's this common misconception that the reason why we have these terrible wait times is that we don't have enough doctors, and that's actually not true. So when you look at the Statistics Canada numbers, only about 40% of Canadian doctors are actually working fully or full-time. So we have this huge amount of excess capacity across the country that is just not being harnessed for a variety of reasons by our existing system. At the same time, there's so much evidence from the rest of the world that solutions like virtual care actually work. They're an effective way to provide healthcare. So greatest examples are provided by hospital systems like Kaiser down in the US, which has over 10 million patients, so about the same number of people as all of Ontario. Last year, they did about 13 million virtual visits. They actually did more visits by video and instant message than they did in person. And between those virtual visits and those in-person visits, there was actually no increased rate of misdiagnosis, no increased rate of litigation, no increased rate of complaints. The only big difference between the virtual visits and the in-person visits were that the doctors were happier and the patients were happier and the costs were lower. So it was a win on almost every dimension. So we started Maple 3 years ago, trying to bring virtual care to Canada, to try to actually bring greater access to healthcare, understanding that provincial governments were not covering this service across the country. So what have we built so far? We built the largest network of physicians on a private virtual care platform around the country. It's the only platform that exists across all of Canada. We're in every single province. We're the only platform that operates 24 hours a day, 7 days a week. On every single encounter, people connect directly to a physician. So very much like Uber, when you click to get a doctor, you go straight to a doctor. There's no intake coordinator. There's no nurse that you have to go through. This isn't gated. We let people go straight to the doctor that's going to actually solve their problem. We have fully built-in medical records so people can store things like their medications, their immunizations, et cetera. I can't even tell you the number of times I've seen patients in the emergency room who come in to see me who they can't remember when their last tetanus shot was, and we unnecessarily give them an extra one. Or they can't remember what medications they're on, and we give them medications that interact dangerously with what they're on. So with Maple, that doesn't happen because everywhere they go, all of these records are in their pocket in the app. We have the largest network of doctors on any virtual care network in Canada. We have over 200 practitioners. We also facilitate things like specialist referrals and laboratory testing for our corporate clients. We have an incredibly high satisfaction rate. So since we've started a few years ago, we measure satisfaction after every single visit. It's one of our leading indicators that we look at. So just like when you have a visit on Uber or Airbnb where you rate your experience out of 5 stars, our patients on Maple rate their experience out of 5 stars. So far, 98% of our patients have rated their experience as 5 out of 5 stars. We also have digital prescribing. We can send prescriptions digitally to any pharmacy in the country. We can deliver medications with partner pharmacies to anywhere in Canada. What does it look like? So this is what it looks like. This is our mobile app experience. We spent about a year developing this, focus group testing it. We realized this was a new way for people to get care in Canada. If it wasn't super easy to use and super fun to use, people wouldn't do it. It's super seamless, really simple and straightforward. Our oldest patient's 92 years old and uses this without difficulty. We have patients ranging from 18, which is the youngest age at which we'll take an account holder, all the way up to the 90s. Really straightforward experience where you can tell the doctor what you're coming in for, see the doctor you're speaking to. We've built a virtual consultation room that includes messaging, video, things like telephone interactivity for people that are in low bandwidth areas where we can switch to a phone call at any point in time, digital prescriptions, and really seamless digital prescription fulfillment process at the end of the visit. This is one of the use cases, so there's a few things that insurers are really interested in us for. So one is on the group benefit side. We've been selling a lot directly to employers. We've also been selling to employers through benefit providers and group benefit insurers. So clearly, one of the greatest drivers of cost for most employers is disability. So the average Canadian is missing over 8 days of work due to illness and disability. When you add up just those direct costs from disability, so never mind the indirect costs, so the loss in productivity, the cost of replacement workers, this is just those direct wage costs. What you're looking at is you're looking at an enormous cost for the average employer. And so what we always say to employers when we go out to them is we say, we don't expect that our solution is actually going to prevent all 8 days of absence per year per employee. But do you think that if every single time your employees needed to see a doctor, instead of taking a day off of work, which is what they do now, they can see one of our doctors online, do you think maybe you could bring that average down by 1 day, just from 8 to about 7? Most employers say, I'm willing to take a shot on that. And for a sample company of about 250 employees, that works out to about $60,000 in savings just in direct costs. Never mind indirect costs, which are often more than double what the direct costs are when you actually factor in everything involved in indirect costs. So just to tell you the yardstick on that, since we started, we have yet to have one enterprise client leave us. So every single client that we go out to, we say to them, if you're not realizing savings or happy with this within 60 days, we'll stop the program. We won't even charge you for the first 60 days. We've never had one client cancel on us. So that's one of the use cases. I don't have slides prepared on it. A couple of other use cases that we're actually quite involved in. One is travel. We service a number of different travel insurers. Obviously, this is a direct cost savings for travel insurers. For both Canadians traveling outside of the country and visitors to Canada, our visits are just cheaper than any in-person visit is ever going to be. So we have travel insurers preferentially sending their travelers to us versus to the in-person clinic or to the emergency room. Just as a, off the top of my head figure, the average visit cost for a patient in the United States to go to the emergency room, even if you're going in for a basic thing like a urinary tract infection, starts at $1,200 US. Our visit's about $50, so it's a lot cheaper. The other use case that we're really exploring, actually we're doing a number of pilots with Aviva Insurance. One of the things we're really excited, we're in the early stages of exploring, is the ability to reduce cost of claims for auto insurance claimants. So as we all know, cost of claims are going up dramatically in auto insurance. One of the biggest drivers of this is that the person gets injured and immediately gets put in touch with a shady physio clinic and a shady lawyer. Next thing you know, they're taking you to court. So what we said is, in the long run, wouldn't it be great if after every automobile vehicle collision, what happens is that claimant, if they have an injury, gets put in touch directly with the doctor on our system, where they're dealing with somebody who has a clear set of guidelines for treatment, for therapy, with referral networks to reputable preferred providers, et cetera. And by doing this, you can take a huge percentage of those claims out of the tort system, massively reducing cost of claims overall. So what have we built so far? I've already spoken about our primary care network. Mental health is a key thing for, I think, everybody across the country. We hear it all the time in insurance. Most employers ask us about it. We just launched the first on-demand psychotherapy mental health service in Canada. So 7 days a week from 8 a.m. to 8 p.m. Employees that are signed up with our service can log on with the click of a button, be speaking to a mental health therapist in the matter of minutes. One of the biggest issues with existing mental health programs is people can either book an appointment in person and be seen weeks later, or there are video service. But again, even when they book some of the video services that are available, that appointment occurs days later, not at the time of need. Sometimes we can prevent an employee absence or prevent a disability by actually intervening right away, and that's what our service allows. It's mental health care immediately right at the time of crisis. The other thing, which may be less relevant to this audience, but something we're really excited about, is we actually just launched a virtual hospital service. So there's a hospital in Prince Edward Island, and we're about to launch some more where we're fully keeping them open, virtually staffing them with doctors that are across the country. And it's our plan to keep rural hospitals open across this country that up until now have struggled to stay open just because they don't have enough doctors. Why are we scalable? I think that was one of the big questions. So we have the largest doctor network. We've actually capped our doctor numbers for now at 200. We're way overstaffed with that, even though we have well over 100,000 patients on the platform. I think I'm out of time. But it's incredibly scalable, and I'll stop right there.
Okay. Judges, we'll go right into the questions.
It's, so who pays for it?
Usually the employer, so it depends on what use case you're looking at it. So when it's a group benefit setting, usually the employer is paying a per employee per month fee.
Okay.
The idea being that their savings in terms of productivity losses from all the disability or from all the absences and that would be prevented more than make up for the fees that they pay.
And to what extent has your business to date been direct to employers versus being bundled in with a benefits package?
So it started out much more heavily direct to employer just to prove the use case, to get the testimonials. Now most of our biggest clients are being fed to us by group benefit managers, providers, insurers.
How do you deal with fraud and those types of things?
So fraud typically isn't so much of an issue. Number one, we don't prescribe controlled medications. That would be one of the drivers of fraud. So it's illegal actually for physicians in an online setting to prescribe any controlled medications to a patient they haven't seen before in the physical setting. So that diverts a lot. The other side of the equation...
They just refer people then, right? So it becomes a glorified referral service.
No, we actually resolve 91% of the medical issues that come in. So 91% of the patients that we see never have to see a doctor in person. So 1 in 10 of those visits are things that require some form of invasive examination or invasive procedure, and we'll have to refer that to a clinic. We haven't yet perfected the art of virtual stitching or virtual broken bone fixing. We're hoping to get there at some point in time, but we're not there yet. But most of the time, we are fully resolving the issue that people are coming in for. The other thing as well is when you examine somebody on video, it's very hard for them to fake. So, somebody who tells you they have the flu or tells you that they, can't lift their arm, well, we can do just as effective of an examination on video as we would do in our physical office. And most of the data that's out there on virtual examination proves that that's the case.
One more question, just on the physician stuff, right? So you made a comment some time back that said that only 40% of the physicians really have full-time roles or something to that nature. Mm-hmm. By going down this path, are we going to reduce that number further?
No, the idea is that we're trying to take those 60% of doctors who are not working full year full-time, and we're trying to bring them closer to full year full-time. So none of the doctors that are on our platform are saying, this is my full-time job. All of them are people that, like myself, who are an emergency room physician who has a full set of shifts. And just to give you an example, when I was working full-time as an emerge doctor, a full set of shifts for an emergency room doctor was 15 shifts a month. Almost nobody works more than that. So you've got a ton of emergency room doctors, for instance, across this country, who half of every month are doing nothing and would love to be able to provide some flexible patient care, but there was no option to do so before something like this came along. So the idea is, let's take all those emerge docs, take them from 15 patient care days a month to 20 or to 22, whatever they feel is their actual amount that they'd like to be giving. So we're trying to actually use excess capacity the same way things like Uber or Airbnb are using excess capacity of people who are willing to drive or excess capacity of people who have homes they're not using.
I think the potential for many use cases and tons of growth in this is pretty clear to me from what you've said. What isn't obvious to me, and I would see as a risk you must have thought of, it looks fairly easy to copy. What is really unique or proprietary about what you're doing that makes it impossible or difficult for, once you've mastered and figured it all out, for somebody else to just come along and do the same thing and kind of eat your lunch?
Where do we begin? So it's funny, we do get this all the time. People say this is really easy to copy, and what I would say is, from the outside it may look that way. I can tell you this is probably one of the hardest things that I've ever done, and what in terms of other people that have actually seen the inside of our business and seen the complexity involved, most of them say, I can't believe how complex this is. So just as a starting point to actually be a truly national provider of a service like this, you're not dealing with one legislative framework, you're dealing with legislative frameworks of 10 provinces, 3 territories, all of whom have their own rules about healthcare provision, their own rules for prescribing, their own rules for data security, privacy security. So we have to have a regimen that's actually compliant across the country. So that's number one. Dealing with physicians, recruiting physicians, training physicians, screening physicians is not an easy job. The average hospital actually struggles to deal with maintaining a physician staff properly, keeping them up to speed, making sure that they're practicing properly. We have more physicians on staff now than most hospitals, and that's something that we're able to do. We've built the capability. To build this system, from scratch, and we're still learning. There are things every day that we realize we could do better. This is a tremendous undertaking. So what I've said to everybody else, and I remember there was an investor we spoke to about a year and a half who said, you know, I could replicate your entire business. Just give me $500,000, I'll do your whole business. So there's no way I'll invest in you. So anyways, that guy went and blew about $500,000. He's still got nothing to show for it. So to anybody who says they can easily do it, I say go ahead and prove me wrong.
Good question on your subscription model. It's $30 for an individual, $50 for a family per year. Is that correct? If you're not part of a benefits plan?
Yeah, that's the retail pricing, yes.
And what kind of discount do you get as a benefit as a business owner if I want to buy it for my employees? Am I paying the $30 to $50, or do I get a discount, or do I buy that through Sun Life, my benefits provider? How would that work?
So it's very substantially discounted if you are a benefits provider or if you're a large employer. So the size of the discount is really dependent on the size of the group. So main reason being is that utilization is far, far higher when somebody goes and buys their own package. So if I'm a family and I pay my $50 a month, I'm going to use this thing all the time. Whereas when your employer buys it for you, use it really only when you need it. And so we're seeing much more predictable and much more low utilization rates among the corporate employees. It's being used responsibly. And so I won't get into all the details of pricing, but it's quite a substantial, almost majority discount off what you're seeing in the retail setting.
Brett, guy's about to cut you off, so 1 second, though. One thing that you should, though, be able to address, it's a good question, is at least for presentation-wise, to be able to address the TAM, your addressable TAM in Canada. You know, in the U.S., this has been done a couple times, but there have been multiple winners. So to addressing that question you had of, I can do this, well, maybe, but it's all about the network effect. And then 2, making sure you can differentiate between your lifetime value to CAC and understand the cost to acquire and how it's differentiated and how you're actually seeing incremental benefits from the employer channel. I think if you can answer those 2, will be some of those questions you've gotten asked, you'll be able to bypass those questions.
Yeah, I mean, I know we're out of time, so I could give you the really brief answer. So the addressable market is actually pretty substantial. So there's about 180 million medical visits per year in Canada. We think about 50% of those are addressable. So if you're looking at 90 million visits addressable per year, and we actually think it's going to be a much bigger pot than that because we actually increase the total number of visits when we actually make visits not impossible to get. Multiply that out by an average visit cost of about $50 to $70. You're looking at somewhere on the order of $5 to $10 billion in value for the market. As a comparable U.S. provider, someone like Teladoc, which is about 10 times in a market 10 times bigger than us. They're the largest provider. They have a market cap of about $2.3 billion US dollars. They do about a million consultations every single year. We're actually, in terms of provider size, about 1/10 of where they are right now. The last question is long-term value over CAC. We already figured that out. It's about 3.4 right now for us.
All right.
Thank you.
Thank you. Good job. And with that, we'll turn it over to the pack leader and announce the winner.
Right. Well, I mean, all 5 of them are winners, except in the sense of winning this contest, in which case there can only be one. But the Wolfpack judges, we tallied up the scores, and the winner was Maple.